everyone, and welcome to today's webinar, Understanding the Mechanisms of Resistance in CAR-T Immunotherapy for Lymphoma and Strategies to Overcome Them. I'm Cassie Soltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Beckman Coulter Life Sciences. To learn more, visit www.beckman.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box in the lower left and click Submit. We'll answer as many of your questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you are having trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Marco Ruella, Assistant Professor of Medicine at University of Pennsylvania. Dr. Ruella, you may now begin your presentation.
Hello, everyone. First of all, let me thank LabRoots, the organizers, and Beckman Coulter for giving me the opportunity to present our most recent work during this webinar. The title of the webinar is Understanding the Mechanism of Resistance in CAR T-cell Immunotherapy for Lymphoma and Strategies to Overcome them. These are my disclosures. CAR T-cell immunotherapy is now an established form of immunotherapy that includes the collection of patient T-cells, as you can see here to the left, the engineering of the T-cell using viral vector, can be lentiviruses or retroviruses. Now the patient T-cell can express on the surface a chimeric antigen receptor, or CAR, by which they can recognize an antigen that is expressed on cancer cells, for example, CD19 or BCMA. And once they recognize the antigen on cancer cell, they kill it. And as you can see, they can destroy the target cell, but at the same time, they can also then proliferate, get activated, and kill many other tumor cells. Just to show you how it looks, not in a cartoon, but in actual real life, at least in the lab, you will see here in red the CAR T cell against CD19, and in green the tumor cells that are CD19 positive. And as you can see here, the CAR T cell can rapidly bind to the tumor, and that will cause the death of the leukemic cell. Those bubbles are the apoptotic cells. And obviously, this process was adopted. The first CAR T-cell product to be approved was tisagenlecleucel that was initially developed by the group of Carjun at the University of Pennsylvania and then licensed to Novartis. But as you can see, it was approved in 2017 in August for pediatric and young adult B-ALL in third line, but has subsequently received approval for large B-cell lymphoma in third line and follicular lymphoma in third line. And in 2017, when we received the notice of approval by the FDA, of course, we were very happy. There was a big celebration, as you can see in this picture. You can see here Carjun. This is Bob Wonderhide, the Cancer Center Director. Kevin Mahoney, now CEO of the healthcare system. And I was traveling, unfortunately, so I decided to Photoshop me here in this picture, so I became part of the group. Besides jokes, after the initial approval of tisagenlecleucel that you see again here, several other products have been approved for different indications. Yescarta, initially approved a few months after tisagenlecleucel for large B-cell lymphoma, and now we have several other products that target CD19 and BCMA for multiple myeloma. So it's really a very exciting time for CAR T-cell therapy for cancer. And these are the curves at long term for Axicell, which is the second product I mentioned, is the CD19 CAR, which differs from T-cell or T cell because axi-cell is characterized by a CD28 costimulatory domain, while T-cell has a 4-1BB costimulatory domain. And you can see in these curves published recently that for both diffuse large B-cell lymphoma and follicular lymphoma, the progression-free survival shows a plateau, meaning that a group of patients at long term are likely to be cured, about 30% for diffuse large B-cell lymphoma and 50% at 3 years for follicular lymphoma. Our own group has published similar results, but with T-cell, and what we publish here is the 5 years follow-up of progression-free survival in diffuse large B-cell lymphoma. You can see, again, quite excitingly, about 30% of patients can be defined as cured for the LBCL, and again, about 40% for follicular lymphoma are in remission at 5 years. So a big interest and the focus of my lab is trying to study what is causing these patients to succeed or these patients to fail CAR-19 so that we can develop then better approaches. And an interest also of our group is to understand what are the potential toxicity mechanisms, because as I will mention later, CAR T-cell therapy is associated with significant toxicity, in particular cytokine release syndrome and neurotoxicity or ICANS. So first I would like to discuss the issue of resistance to CAR T-cell therapy. And in particular, as you can see in this cartoon, we try to summarize what are the currently known mechanisms of resistance to CAR T-cell therapy. And this was published by Dr. Gilardi in my lab in the British Journal of Hematology. And I always like to start considering the pre-infusion barriers. And I think this is important because any reason by which you cannot infuse the product is per se a cause of failure of a treatment. And in the case of CAR-19, we know that there are issues with potential manufacturing that can take time, and during manufacturing, the patient can progress of his disease or her disease. There are patients that unfortunately cannot receive the product because the product fails manufacturing. This is still an issue, although in a small percentage. But also, I think it's important to consider the issue of access. So if a patient lives in an area or in a country where there is no CAR T-cell therapy, or there are not the socioeconomical situation that allows the CAR infusion, well then, per se, that's a reason for failure. But if we focus more on the biological reasons for failure that you can see here, also in yellow, we identified 3 main categories. One is the so-called CAR dysfunction. So again, as you can see here, the tumor cell and the CAR T cells. So there are a lot of reasons why this interaction might fail, and one of them is the fact that if the T cells are exhausted or are terminally differentiated, they would not be able to generate a potent and prolonged anti-tumor effect. The second mechanism is the role of the tumor microenvironment and host factors in general. We know that within the tumor or within cancer patients, there are a lot of inhibitory factors like T regulatory cells, tumor-associated macrophages, myeloid-derived suppressive cells, and so on, that can cause significant inhibition of T-cell function. And lastly, I want to mention tumor intrinsic mechanism. So in other words, tumor cells evolve under the pressure of CAR T cells and develop mechanism to resist to CAR T cell killing. Probably the most famous one is the loss of CD19 on the surface of the tumor cells upon pressure, selective pressure of CAR-19. And this has been observed in a significant subset of patients treated with CAR-19. And we have done several studies studying the role of apoptosis in modulating tumor cells, and they are resistant to CAR T-cells. So I want to start with discussing a little bit both the role of the microenvironment and what we can do to T-cell to make them better killer of cancer cell. And this is work that is being studied by Puneeth Guru Prasad in the lab. And this work really started by thinking about all the players in the tumor microenvironment and how they can affect CAR T-cell function. And in particular, we focus on regulatory T-cells that are well known to inhibit T-cell function in the microenvironment and myeloid cells. And to do that, we use a Hodgkin lymphoma model. So why did we use Hodgkin lymphoma? Well, we use Hodgkin lymphoma because it's a lymphoma where the vast majority of the tumor bulk is comprised of stromal, inhibitory, and microenvironmental cells. So the vast majority of the tumor is actually tumor microenvironment, while only 1 to 2% includes malignant cells. And so we perform single-cell RNA sequencing in these patients, and we identify several subsets. You can see monocytes, fibroblasts, B cells, and a lot of T cells in the microenvironment. And we try to study the interaction between these different clusters by using a software, an algorithm that is called cell phone DB. And interestingly, by looking at the interaction between inhibitory cells and cytotoxic CD8 positive cells, we identify BTLA in T cells and HVEM in the inhibitory cells as one of the key interactions in the tumor microenvironment that might lead to inhibition. So what is BTLA? Well, as you can see here, BTLA is a novel checkpoint that is expressed in T cells and also in B cells that when binds to HVEM, predominantly in trans, but it can also be bound to HVEM and cis, it will inhibit the T cell receptor signaling through the phosphatases SHIP1 and SHIP2. Interestingly, I think that given the fact that now we have tools such as CRISPR-Cas9 and in general gene editing, we hypothesize that disrupting BTLA in CAR T cells would enhance CAR T cell function by removing an inhibitory molecule in the T cells that can recognize HVEM in a cancer or stromal cell. We did a knockout using CRISPR-Cas9, and as you can see here, we obtained a significant knockout of BTLA. We were able to express a CAR. We use as a model a CAR against CD30, and CD30 is a known antigen for Hodgkin lymphoma. And to make a long story short, I would like to show you the in vivo experiments. In this model, we inoculated mice with a Hodgkin lymphoma cell line. So these are immunodeficient mice, NSG mice, injected with the human cell lines. And when the tumor was established, was measurable, we injected mice with the CAR T cells or control T cells that don't have any CAR on the surface. And what you can see here from the results, the CAR T cell that had been deleted for BTLA in red, they had a much better tumor control as compared to the wild type CAR against CD30. And this is shown also here in this overall survival curve, where really the only mice that are surviving a long term are the BTLA knockout mice, BTLA CAR30 mice. So we propose that this system of BTLA knockout can also work in other models as long as the tumor would express HVEM. And so what we show here, this is now a non-Hodgkin lymphoma model. So we're not using CD30, but we're using a standard CD19 targeting CAR. And what you can see here is that we are able, with the BTLA knockout, to prolong the survival of these mice as compared to the standard 4-1BB co-stimulated CAR19. But obviously, these models do not include a tumor microenvironment. So we want to develop a system where a tumor microenvironment was present. And to do that, we turned to an immunocompetent Munich model using BALB/C mice that were engrafted with the A20 lymphoma cell line. Puneeth in the lab developed a strategy to knock out BTLA in the mice, in the mouse T cells. And obviously, as you can see here, the analog of BTLA is now in chromosome 16, not in chromosome 3. And we got pretty efficient knockout of BTLA in murine CAR that were then injected into mice, and we followed them up for tumor burden and overall survival. And what you can see here, the tumor volume of mice that were treated with the BTLA knockout was much more controlled by the T cell, and the overall survival was also drastically better with the BTLA knockout. To prove that this pathway is really important, we then did another experiment where instead of blocking BTLA, we actually stimulated BTLA to sort of prove the point that the T cells are inhibited. And as a result, what we found is that if you stimulate BTLA, you actually get a pretty quicker tumor progression as compared to the controlling antibody. And as I mentioned, the mechanism that we propose based on the literature is that by removing BTLA, you have reduced activity of SHP1 and SHP2. And as you can see here in this phosphoflow assay, we show that BTLA knockout CAR30 have lower levels of phosphorylated SHP1 as compared to the wild-type CAR30. Clearly, there are a lot of these knockouts and of checkpoint inhibitors in the clinic. And so we wanted to sort of focus on the one that are really being used in the clinical setting. And in Hodgkin lymphoma, the PD-1, PD-L1 axis is particularly important because there are FDA-approved checkpoint inhibitors like pembrolizumab and nivolumab, which have been used in our patients and that they have been efficacious. And there are also trials in general in CAR T cells where PD-1 is knockout to enhance CAR T cell function. And so we compare head-to-head PD-1 knockout to BTLA knockout, and at least in this model and in all the models that we tried, the PD-1 knockout was performing a little bit better than the wild-type CAR30, but BTLA was significantly better in improving tumor control, as you can see from the progression-free survival, or I should say the tumor burden over time, and the overall survival to the right. And lastly, we wanted to understand the clinical relevance of this approach while we wait to translate that to a clinical trial. And so we look at the patient that I showed you earlier. These are the patients that we've been following for 5 years in the clinic. They were treated by Steve Schuster and colleagues in the first trial with CAR19 for lymphoma at Penn, single center. And what you can see here that when you analyze the products, the CAR T-cell product, interestingly, patient with a complete response, they had less BTLA in the product, and this correlated with the progression-free survival. In other words, patient with a product with low BTLA did much better than the patient that had high BTLA in their product. Again, we go back to this slide to say that we have been working on the microenvironment. I've shown you a strategy to improve CAR T cell based on the finding that we captured in the tumor microenvironment of Hodgkin lymphoma. Now I want to switch gears and move into a translational project that in collaboration with a company called Abclon, we were able to bring truly from bench to bedside. And the goal of this project was to develop a novel CAR against CD19 that we hypothesized could be better because of a few characteristics related to the CAR construct that make it quite unique. So what are these characteristics? Well, as you can see in this 3D reconstruction of CD19 on the surface of B cells, all the commercially available CAR and most of the antibodies actually recognize the epitope of the FMC63 antibody. So all the four commercial CAR products, they all recognize this specific epitope. So Abclon developed an antibody based on a chicken library that would recognize a different epitope of CD19. Interestingly, an epitope that is closer to the membrane as compared to FMC63. And the second characteristic, in addition to the epitope, was the fact that the new construct that we call it 1218 is a construct that binds quickly to the target and detaches quickly. You can see it here in blue, quick attachment to the target and then fast off-rate. And so this characteristic that would lead to a low avidity of the CAR, we hypothesized could be beneficial in causing an enhanced T cell function by reducing the early stimulation. So starting with the epitope and the characteristic, we hypothesized that targeting an epitope that is different than the ones of the currently available products could be beneficial. Why? Because there have been mutations described in the epitope that is recognized by FM63, and therefore targeting a different epitope could be beneficial because could overcome that specific resistance. And two mutations that you can see here in position 174 and in position 163 have been described in the clinic. And so in order to test the hypothesis that 1218 can overcome these mutations, we developed a model where we inserted these mutations in NAM6, a standard CD19 positive leukemia, and we treated the mice with control T cells. So these are T cells without the CAR, the standard CAR T cell that recognize FM63, and the new 1218 CAR T cell. And as you can see, the only one really that were able to control the tumor were the new ones, the 1218, and this was true for tumor burden, but also for overall survival, and was further confirmed by higher proliferation of the 1218 in the peripheral blood of these mice. Then another potential advantage of the epitope closer to the membrane could be a better T cell function. And so we compare head-to-head in leukemic cells that have wild-type CD19. And what we found in multiple experiments is that the 1218 was actually performing better than the FMC63. And this was, as you can see, pretty dramatic in this model, and was associated with better overall survival, better expansion of the CAR T cell that, as you can see, are higher at day 14, and in general, they continue to be higher at long term. So all of these concepts were then translated into a clinical trial that was run by the company Abclon in Korea, and then was led by the principal investigator, Dok-Hyun Yoon. The trial is a phase 1 dose escalation trial that included a 3+3 design, and when patients were enrolled, they would receive a leukapheresis. While the product was being manufactured, bridging chemotherapy could be used. And in the week before the infusion of the product, lymphodepletion would be received with a pretty standard fludarabine and cyclophosphamide for 3 days. And then 3 different cohorts were infused with increased doses of AT101, which is the clinical grade product name for 1218. And so these are the cumulative results that I think are pretty interesting, because as you can see here, due to a dose-limiting toxicity, cohort 1 had to include 6 patients. Luckily, there were no dose-limiting toxicity in dose level 2 and dose level 3, so dose level 3 was chosen as the recommended phase 2 dose. But you can see that if we look at overall, the complete response rate was high. As you can see, there are in the first cohort 3 patients with a complete response, but if we look at those level 2 and 3, 100% of patients reach a complete response. And many of these patients are still in complete remission at long term. As you can see, 2 patients over a year, 3 patients over a year, and other patients are approaching the year or they are past 6 months. So limited number of patients, but I think overall promising results with this new construct that binds to a different epitope with a different ability. And lastly, I would like to focus for the remainder of my time on the issue of CAR toxicities. So CAR T-cells have been very effective in B-cell leukemia and lymphoma, and also in multiple myeloma, but we have discovered completely new toxicity mechanism and toxicity syndromes that we were simply not experiencing, at least to this level, with other therapies. And the 2 main ones are the cytokine storm or cytokine release syndrome and the neurotoxicity, also called immune cell associated neurotoxicity syndrome, or ICANS. Everything, of course, starts from the interaction between the CAR T cell and the tumor cells. Upon and after this interaction, there is release of cytokines that in return activate stromal cells and myeloid cells like monocyte macrophages or endothelial cells, or another stromal cell that would release additional cytokines, and that causes a generalized inflammation with fever, with systemic symptoms that can be hypoxia and very low blood pressure that can require intensive care unit admission. And so over the years, we have learned how to manage the syndromes using IL-6 receptor blockers, steroids, and other drugs, but still a significant number of patients, especially with some of the CAR-19, especially the ones that are stimulated with CD28, experience toxicity, and in some cases is quite difficult to manage. So when we compared all the different trials that you can see here, the first 2 are with a CD28 product, the second 2 with a 4-1BB product. As I mentioned, the rate of neurotoxicity is quite elevated. About a third of the patient has severe neurotoxicity with the CD28 construct, while it's in the about 10% in the 4-1BB co-stimulated. And beside the construct itself, we also noticed that there were differences in the way the lymphodepletion chemotherapy was given. Slightly different doses and mostly similar agents, which means fludarabine and cyclophosphamide. But in the case of the T cell for lymphoma, we've also used bendamustine, which is another chemotherapy that has been used for patients with hematological cancer. So we asked the question, can lymphodepletion have a role? Can lymphodepletion affect these toxicities? And why we hypothesize that? Well, because lymphodepletion is an essential step of CAR T-cell therapy, and this has been shown by several investigators, including probably pioneered by Steve Rosenberg at the NCI. And how does it work? Well, it works by creating the right cytokine environment with IL-7 and IL-15, and also the physical space for CAR T-cell to engraft and to proliferate. Lymphodepletion is thought to be working also through the elimination of Tregs that are inhibitory to effector T cells, but also by modulating the tumor and potentially allowing more CAR T cell to enter the tumor bed. And lastly, I think we still more on the speculative side, but the thought is that lymphodepletion might generate immunogenic cell death or exposing antigens for recognition from the T cell, but also stimulate antigen-presenting cell maturation and affecting the translocation of bacteria from the gut to the bloodstream, again stimulating immune function. Again, a lot of these things still need to be determined, but we wanted to start analyzing this concept by looking at our clinical data. And so we had the advantage of having a large cohort of patients that was treated either with fludarabine and cyclophosphamide, pretty standard lymphodepletion therapy, as you can see here and here. But interestingly, as mentioned, we also consider bendamustine, which includes portions that are of the chemical structure that are similar to fludarabine and also to cyclophosphamide. And so the first cohort of patients that we analyzed was the group of T cell. So these are the patients with treated with a 4-1BB co-stimulated CAR. And overall, we analyzed 132 patients that were collected from 3 centers, Penn, the group from Oregon Health and Science University, and the University of Vienna. And in the first type of information, we wanted to know about the ability of the chemotherapy to lymphodeplete our patients. And both of them, as you can see, are pretty potent agents for lymphodepletion. But what Guido Gilardi in my lab showed is that the fludarabine and cyclophosphamide in red, that this combination causes more profound lymphodepletion. Does that correlate with response? Well, not in our hands. As you can see here, the overall response rate is similar between the two lymphodepleting regimens and also the overall survival. But when we analyzed the toxicities, well, then there was significant difference. You can see that the cytokine release syndrome is much lower with bendamustine, and likewise the neurotoxicity it's even more pronouncedly decreased in the bendamustine as compared to fludarabine and cyclophosphamide. These are all patients with large B-cell lymphoma, and of course it's a retrospective study, so it's not random. So we then look at the hematological toxicities to check if there was a difference between the two groups. And again, remarkably, fludarabine and cyclophosphamide were associated with lower neutrophils, platelets, and hemoglobin, basically at every single time point that we analyzed. And if you just look at the lowest values, it's very profoundly clear that fludarabine and cyclophosphamide are much lower nadir as compared to bendamustine. And lastly, as a consequence, or partly as a consequence of these cytopenias, as you can see here, infections and neutropenic fevers were significantly, I would say drastically higher with fludarabine and cyclophosphamide as compared to bendamustine. Overall, when we treat these patients, obviously it's very important to understand if we can use these CAR T-cell products in the outpatient setting as compared to the inpatients. And you can see that overall the hospitalization rate or the infusion setting was clearly different between the two groups, with the bendamustine treated patient being admitted less, being treated mostly in the outpatients, and so on. So the next step was to analyze a product that has been shown to have more toxicities, in particular CRS and ICANS, and this is Axicel. Axicel is a CD28 co-stimulated product, and in this case what we analyzed, there were about 60 patients with large cell lymphoma or follicular lymphoma. As you can see, these are the two groups. They are overall comparable for the clinical variables that have been associated with outcomes after CAR T-cell therapy. And interestingly, also in this case, we couldn't see any difference in complete response rate or partial response rate between the two groups. And also when we look at the progression-free survival, and you can see this was true in both groups, both large B-cell lymphoma and follicular lymphoma, we couldn't see any difference in the efficacy outcome. Interestingly, when we look at the expansion of the T cells to see if the lymphodepletion, the different lymphodepletion had an effect on the expansion, we couldn't find any clear difference in expansion of the T cells at day 7. At day 7 to 14, we chose the highest value, and we couldn't find any difference in the phenotype, and in particular the memory subset, based on lymphodepletion. However, again, also in this case, when we look at the toxicities, we discovered that CRS was reduced in the bendamustine treated patients, and also neurotoxicity was significantly lower in patients receiving bendamustine. Infection and neutropenic fever were reduced, and this was linked to a difference in the cytopenias, with neutrophils and hemoglobin being lower in the flu-cy group as compared to benda. Of course, it's important also to look at long-term, and if we look at 6 months after infusion, the only really difference is that patients treated with flu-cy, they still have lower lymphocytes as compared to benda, while neutrophils, hemoglobin, and platelets have now normalized. So we tried to gather a little bit of mechanistic studies about these two lymphodepleting regimens. And we performed cytokine analysis and metabolomic analysis. And this was done pre and post lymphodepletion. It's interesting to see that a lot of cytokines are differentially expressed in the two groups, with most of them being higher in the flu-cy. Some of them are the known factor like IL-15 or IL-2 and so on. But interestingly, there were quite a bit of factors like MCP1, MIG, and MIP, and other ones, GM-CSF, that were higher in flu-cy. And these are factors that have been associated with neurotoxicity. And so potentially they can explain some of the increased toxicity in patients with flu-cy. And lastly, in the metabolomic analysis, we observed more catabolic pathways in a patient treated with flu-cy. And as you can see here, several different metabolites were differentially expressed in the two groups, clearly explaining that differential effect of the two lymphodepleting regimens on the patient before CAR infusion. So what I've sort of shown you today, I've shown you three stories. The first story is about the role of the BTLA and HVAM axis in CAR T-cell immunotherapy, and we studied from patient biopsies of Hodgkin lymphoma, and then we showed that BTLA knockout can be beneficial in multiple models as long as HVAM is expressed by the tumor or the microenvironment. Now, of course, we would like to explore more this role in solid cancers. But of course, the next step would be to bring this BTLA knockout CAR30 to patients in a phase 1 clinical trial. I then moved to the work of Yunlin Zhang and Ruchi Patel in my lab and the group at Abclon and the collaborators in Korea, where we developed a new CAR against CD19 that have shown beneficial effect in patients, or I should say, patient-derived tumors that have been shown to have mutation in CD19. And we think that part of the increased activity that we see in the lab, but also in patients as compared to FMC63 is due to this different epitope associated with a fast on and fast off rate. Obviously, now the trial will move to a phase 2, and there will be a separate trial including patients that have failed CAR19, which of course will be important to see, to confirm the data that we obtain in the laboratory. And lastly, I switched to thinking about the role of lymphodepletion, and we showed that while flu-cy and bendamustine are equally effective in in generating responses in our patient, in this retrospective study, bendamustine was associated with reduced toxicities, in particular CRS, ICANS, infections, but also cytopenias. At long term, this difference seems to be smaller, only significant for lymphocytes in the peripheral blood. We think that part of this mechanism is due to the secretion of cytokines that can activate the myeloid cells and potentially changing the type of metabolites that are present in the serum upon this lymphodepletion. I would like to thank again LabRoots and Beckman Coulter for giving me the opportunity to give you an update on the work on resistance and toxicity to CAR T-cell of my lab. I would really like to thank my team. As you can see here, I mentioned them while I was presenting. I'm very grateful to them and for their work. And their name are listed here, my lab, the Lymphoma Program, a span that is headed by Steve Schuster, all our group at CCI, CARJUN, the company that developed the CAR30 and the novel CAR19, all my funding agencies, and again, all of you for your attention. And I think we have some time for questions. Thank you very much.
Thank you, Dr. Ruella, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for today. Let's go ahead and get started. Our first question here says, wouldn't high cytotoxic also be toxic to the body?
Can you repeat the question? High what? High cytotoxic?
It says, wouldn't high cytotoxic also be toxic to the body?
So probably yes. So I think it's probably referred to the high cytotoxicity of the CAR T cell with the BTLA knockout that we were doing. Yeah, I mean, certainly this is a good point. So any strategy that tries to enhance the function of CAR T cell therapy can come with the risk of higher toxicities. But I think the whole field is trying to develop stronger CAR T cell, and as long as the toxicity is on target, so we don't get off-target toxicity to healthy tissues, for example, I think we have the tools now to manage them. For example, cytokine release syndrome, neurotoxicity. I think at this stage in 2023, we're able to monitor the patient and manage the toxicities as in a proper way. And so again, absolutely right. Every time you make a stronger drug or a stronger cell product, you might get the risk of higher toxicity. But I think if that's the case, that would be actually a good sign that the product is working. And as long as the tumor is cleared, I think that the treating team would be able to manage CRS and ICANS. But it's a good point.
Fantastic. Thank you. Our next question that we have here, and bear with me, it's a little bit long, says the neurotoxicity associated with anti-CD19 therapies is believed to be due to the recently identified brain mural cells that express CD19. A compromised blood-brain barrier could potentially be a factor, providing an explanation as to why some patients experience neurotoxic effects while others do not. What are your thoughts on incorporating standard blood-brain barrier tests into clinical studies?
Very good point. Yes, the colleague is referring to some recent work that postulated the expression of CD19 in pericytes in the vessels of the brain. This is actually work coming from Penn and San Francisco. But I would say that we do see neurotoxicity also with other CAR T cells. So I think that there are a multitude of factors that affects neurotoxicity. So certainly, potentially the expression of some of the targets in the brain could be one of the causes, but the damage to the blood-brain barrier and the fact that there is a cytokine release that can go and activate cells in the brain, I think that also plays a major role. So your point about having tests to measure and quantify the, let's say, quality of the blood-brain barrier in the clinic would be kind of interesting. But as I'm aware of, that there are no such efforts going on, and so I think it's a great idea, but I'm not aware of studies that specifically run those tests.
Well, thank you. Our next question here says, just to clarify, what is your CD19 domain that your T cells target, and do you have a commercially available antibody to target that non-FMC63 domain?
So the colleague is referring to the mid part of our talk regarding the AT101 product that we developed with a Korean company called Apclon. So first part of the question, yes, we know what domain is recognized, and I think I mentioned that in my presentation. It's a domain that, and the paper will be soon out in Molecular Cancer. It's a domain that is located closer to the membrane as compared to FMC63. And in the paper, we specify the amino acids that the location of that specific domain. The CAR, as I showed the results, has been tested in a phase 1 clinical trial in Korea, and so that's going on and actually is completing. There will be phase 2. But there is no, as far as I know, a commercial antibody available for this specific domain. So the company has the antibody, but I don't think they sell it commercially. But we're always open for collaboration, so feel free to reach out.
Perfect. All right. Our next question here says, what is the mechanistic significance of the fast on-off binding of the membrane proximal CD19 CAR-T?
Yeah, great question. So as you saw from my presentation, the kinetics of binding to CD19 of this new CAR that we developed is quite different than the currently available CAR based on the FMC63 antibody. We noticed that while the affinity is the same, but again, keep in mind that the affinity is given by the ratio between on and off rate. We did see that there is having same affinity, we still had a very different on and off rate. So it binds quickly to the target and detaches quickly. So what we postulated, and we're trying to generate more data on that topic, is that our CAR is able to quickly bind to the target, exert its anti-tumor effect, and then detach and go to target other cancer cell. In addition to that, we saw that these dynamics of on and quick off doesn't lead to extreme early activation of the CAR T cells. So in other words, we're sort of having a reduced activation-induced cell death. So there is sort of a modulation of the activation of our CAR T cells so that they don't die for activation-induced cell death. So I think the combination of these two features, not dying for hyperactivation, and then having the ability to establish multiple synapses and kill the tumor in a sort of a serial killing type of way, I think those are the characteristics that make this product potentially more effective than the standard ones.
Thank you. We are getting a ton of really great questions, so thank you, everyone. Continue to submit them down there in the lower left corner, and we will try to get to them today. Our next question here says, do you think by association of BTLA, knockoff CAR, and anti-PD-1, you could enhance the CAR killing effect?
Very good question, actually. We've been thinking a lot about this because, of course, PD-1, at least PD-1 inhibition, is standard therapy for solid cancer, but also Hodgkin lymphoma, that is where the setting where we initially discovered this target for CAR improvement. So as you saw, we did some work comparing head-to-head BTLA knockout and PD-1 knockout. We're now trying, obviously, to think about combining the checkpoint inhibitor with the BTLA knockout CARs, or likewise to knock out PD-1 and BTLA within the same CAR. On that regard, I have to say that so far, the studies that I've seen, the clinical studies that I've seen that include the combination of a checkpoint inhibitor plus CAR T cell, have not shown really breakthrough results. So it's possible that we might have to learn more about the right timing of combining checkpoint inhibitors as an antibody with CAR T cell. And likewise, similarly, I would say, there have been publications that suggested that if you remove PD-1 from your CAR T cell, there might be defects in establishing long-term memory. So I think it's double-edged sword that where you can potentially improve the anti-tumor effect, but on the other side, you might reduce the ability of these cells to proliferate and survive at long term. So certainly is in our to-do list. We're working on it. But we don't have strong data that we will be able to translate to the clinic quite yet.
Okay, thank you. Our next question here says, what is the primary focus of this research, which I understand aims to improve outcomes for patients with relapsed or refractory hematologic malignancies, particularly in the context of chimeric antigen receptor T-cell or CAR-T therapy?
Yeah, so this is a general question about, the goal of my research that, as I mentioned at the beginning of my talk, is really focused on trying to improve CAR T-cell therapy for relapse refractory lymphoma, myeloma, and leukemia. We try to understand first what are the mechanisms of resistance that we see in the clinic, and learning from those mechanisms, we try to develop better products, better combination that then we test, we bring them back to the clinic and we test in early phase clinical trials. And during this webinar, I show you a few of those approaches, right? I show 3 of those approaches that are at different level. One is laboratory, the BTLA knockout. The other one is retrospective. So look back at the patient that we treated, look at what type of lymphodepletion they received, and then understand the toxicities. And then the last one is actually a first-in-human phase 1 clinical trial. So again, going from patients, understanding the mechanism of resistance and toxicities, modeling in the lab, and then back to the patient for clinical testing.
Perfect, thank you. And it looks like we have time for just one more question today. That question says, are there clinical trials with CARs targeting 2 antigens, e.g. CD19 and CD20? If not, do you think they have potential?
Yeah, I mean, this is a fantastic question. I didn't get the chance to talk too long today about antigen-negative escape, but the loss of CD19 is a significant issue in the field, especially in acute lymphoblastic leukemia, but we also see that in lymphoma. And therefore, for many years, investigators have been trying to develop a CAR T-cell that target multiple antigens. And there are a lot of preclinical papers. We published the first one in 2016, for example. But now there are also published results of products that target 19 and 22, for example, 19 and CD20. We have a trial at Penn that has been presented at ASH, the American Society of Hematology, and will be published at some point soon, where we had 2 products, one against 19 and the other against 22, that show very good results. So a lot of groups are working on those products. I have to say that when you want to use the same T cell to target 2 antigen, there are some specific issues with the design that needs to be considered to make sure that the T cell can target at the same time both antigens. And so the design of the CAR construct really become very important for the success of those therapies. But there are published results for sure.
Perfect. Thank you again, Dr. Ruella, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Beckman Coulter Life Sciences, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.